Hi, I'm Lynn Dietrich with the University of South Florida, and I'd like to welcome you to today's program on HIV testing and billing in Florida healthcare facilities. And I'd like to introduce our speaker, Debbie Sestero-Siefer. She's a master's level nurse educator and training specialist and coordinator of the Expanded Testing Initiative. And you can read more about Debbie if you'd like on the screen, but I'm going to turn it over to Debbie at this point.
Thank you so much, Lynn. Good afternoon, everyone. I took a peek at the attendee list, and I see a number of folks that I know and that I've been working with over the past many months as my role as coordinator of the Expanded Testing Initiative project, and also see some new folks. And I welcome you all and appreciate the opportunity to be able to talk with you today about HIV testing and our initiative. I have no disclosures to make regarding any kinds of financial relationships or commercial entities that I have relationships with. I don't have any of them, so that gives me the ability to speak with you very clearly about some of the Expanded Testing Initiative issues. The objectives today are very clear, and I will not go through each one, but I hope by the end of the program you'll have a better idea about the availability of support to help you at your facility perform HIV testing and work to bill third parties for this testing. I do have a polling question for you all today. I'm interested in knowing what type of organization you represent, and you can see we have all of them listed here. Our facilitator, Ron, has put up a polling question to your right at the very bottom of your screen if you are watching this on your computer. So what kind of organization do you represent? A hospital, emergency department, community health center, Department of Health, college, university-based clinic, private practice, federally qualified healthcare center, community-based organization, patient-centered medical home, and other. Yes, thank you. For those of you that can see the results in the right lower corner of your screen, it looks like we have community health care centers here represented, Department of Health. We have community-based organizations. Welcome, and thank you for joining. And we're also seeing that we have others, and then some folks just couldn't answer, and perhaps that's because you're on the phone, which we're just happy that you're here. Polling question number 2 is, do you currently provide routine testing for all patients, clients in your agency and or clinic? And this is a simple one, yes or no. You can give us that response. Ron will be able to show us those results, because it's always fun on these calls to find out who are we talking with, what is this discussion group. And although I may be leading the discussion in many ways, I want to be sure that I address your individual needs as representing different agencies and also representing different types of scenarios in terms of your testing protocols. Great. So we have a big 31% saying yes. We have some folks that are on the call, 12% that did answer, saying they did not do routine testing. And I really appreciate everyone giving us this information, because it shows that there's people doing different things. And, of course, not everyone could answer. So it'll be interesting when we get chatting up, and you do have the availability to chat on this call, to let us know particularly what your situation is at your agency. Another polling question for you is polling question 3. Do you currently bill for routine HIV testing services? And this follows up with our last question. Many of you are offering free services for testing. I know that. Historically, free testing is what our patients also know, or individuals in our communities. They're familiar with the opportunity to go to different health care facilities or CBOs and receive free testing. But we're interested to find out if you're currently billing for routine testing. And this is a yes or no option. And Ron, I think because it's such a quick question, we'll see right away and close this up and see where we are. All righty, so we do have a lot. We have a few people that are billing, and we will talk a little bit about this towards the end of the program. And we have a lot of people not billing, and I hope that you're on the call because you're interested in finding out what is involved if you are wanting to start third-party billing. And for those of you who could not answer, I'm sure there are many reasons why not, and that you can't do it or that you're not billing. And we hope to get in any questions specifically that you have for us today as well. Thank you, Ron. Well, what do we know about HIV testing and screening in the United States? We do believe that only 54% of individuals have ever had an HIV test in their lifetime. Of those people who have never been tested, 57% reported that they did not get tested because they did not think they were at risk. So individuals feel that they are putting themselves in a risk profile. Whether they feel that they're at risk, then they may be more apt to get tested. Risk-based testing strategies do fail to identify all who need screening, and we do know that late diagnosis of HIV remains common in many regions of our state and in our nation. The awareness of serostatus among people with HIV and estimates of transmission is very clearly represented on this slide. And the thing that I want to bring to your attention is this 20%. And I'm going to take my little arrow down here and point to it. The reason I want you to look at it is because what we're seeing here, that the CDC estimates, that based on very conservative estimates, in fact, that those that do not know that they're infected may represent up to 50% of new infections. So those individuals that don't know that they are HIV positive are transmitting within our communities and in our state a lot of virus, and unknowingly so, versus those individuals who are aware of their infection and also transmitting. But look how many are aware of their infection, and they transmit in relatively less. And we're hoping that because they know they're infected and they want to prevent that transmission. So this is a very eye-catching slide and very important in terms of thinking about HIV testing and making it routine. The 10 states with the highest number of new HIV cases in 2014 was, well, at the top of the list, something we do not in Florida want to be number one in. I don't think any state wants to be number one in this. This is Florida, highlighted in green. We have the largest number of new diagnoses of HIV infections in 2014, and this is continuing. We have other states represented here, and at one time New York and New Jersey were at the top of this list. So it does show that with careful attention and initiatives, we can decrease this number, and it is very clear that Florida has some work to do. We look at the nation, we can see the hot spots, the 25 U.S. cities with the highest rates of HIV infection, and this is from the year 2013. Again, Florida is in the red zone, and 4 metropolitan areas are highest, in fact, have high infection rates. Let's take a look at the HIV epidemic in Florida now very closely. The rates of HIV infection in Florida 2012 to 2014, this slide is very pertinent to this discussion in that the purple areas are dark blue, depending on your color vision. is represented as those areas where we have a very high incidence of HIV infection. But you can see that no part of the state is not affected, and that we have pockets and many pockets, if you will. And so they're looking at a state approach to this. You can understand why we have created this initiative to increase testing. I am located in Broward County, where we have a very high epidemic, and you can see the corridor reaching from Palm Beach all the way to the very tip of Florida. The Florida counties with the highest incidence of HIV in 2014, Miami-Dade ranked number 1, followed by Broward, Orange, Hillsborough, and Palm Beach. So if you are living or working in these areas, you probably already know that we have a serious problem and a serious challenge. But I do want to highlight that the rest of the state has pockets of also high incidence, and I'm glad that you're on the call today. Many of you are familiar with these data. This is the number and percentage of persons diagnosed and living with HIV engaged in selected stages of the continuum of care in Florida. And this is our 2014 data, and it does include the Department of Corrections data. And I am not going to spend a lot of time on this, but I do want to bring your attention to the fact that in Florida, we have about a 58% viral suppression rate. That isn't undetectable. It are those patients that have viral loads less than 200 copies per ml. But we have work to do. That means the virus is in our communities, and those individuals who do not know they're infected are transmitting this known virus. Those individuals who we have represented here on this slide who know that they're infected with HIV are also transmitting virus. So we have a lot of virus transmission. If we look at just a little bit of the infection cases by mode of exposure, we see that the mode of HIV viral transmission in Florida almost mirrors the transition mode for the entire U.S. The most compelling piece, however, and I'm going to bring my arrow down, is this 30%. Hopefully you can see my white arrow. Florida has a higher percentage of heterosexual transmission than is seen in the U.S. as a whole. This is important for us to recognize and to do something about. The second slide here is adult HIV infection cases by sex and race ethnicity reported in 2014 in Florida. And I have to thank the Florida Department of Health for putting together such great visuals for us so that we can take a look at these data. 62% of adult cases of HIV in women occurred among black women here in the state of Florida. HIV is ageless. Women of all ages may not know that their sexual practices may put them at risk for developing HIV and other sexually transmitted diseases. Here from the Department of Health, we see a slide that depicts adult HIV infection cases by age group, and this report runs from 2005 through 2014. And I'll pull my trusty arrow for those of you can see me, and I bring your attention to the line that shows individuals over the age of 50, that's the red line, and then also those individuals aged 20 to 29, the blue line. These lines are not going downward, they are plateauing and going up and rising. So this is a serious makes a serious case for the fact that HIV transmission is ageless. It is no longer one age group that is affected. So again, my point is HIV is ageless. Persons in their 20s may not think that their sexual practices put them at risk. Remember from a previous slide, oftentimes patients do a risk profile on themselves, and they may not think that their sexual practices put them at risk for getting HIV and other sexually transmitted diseases. Here's another slide from the DOH that very clearly represents the age issue that I've been trying to bring to your attention, and that is those individuals under the age of 50 and then those individuals over age 50. Again, HIV transmission is ageless. I'm sorry that I sound like a broken record, but I really want you to bring home something from this presentation today. Older persons, especially who may not think they're susceptible or that at risk for HIV, may be widowed or divorced, and they may be unaware of the risk of HIV and STDs. They may also be at higher risk for social isolation, depression, and stigma because of their age, and they may not go in for testing. And their providers might not think of testing them because, again, as providers, we also have in the past thought of risk profiles in determining who needs to get tested. So in the beginning, when HIV was very new to us in the early 1980s, and we lost so many of our friends and companions to HIV, we were targeting individuals because we thought we understood that certain risks brought about the possibility or higher risk of transmission of HIV. That was in the beginning. The historical background is as the CDC became more involved in following the disease, HIV as a disease management and treatment, we found that in 2006, CDC was recommending a new set of guidelines that called for automatic, routine, or universal testing of all adults and adolescents ages 13 to 64 years of age attending a healthcare setting. These guidelines also strongly recommended removal of barriers to HIV testing where allowed by law. The benefits of this opt-out testing included the removal of the need for written consent and pre-test HIV counseling, and this was highlighted in this report. Now, this did not change laws, but it did encourage laws to be changed so that individuals could be tested within this age group on a routine basis. In 2014, better late than never, we had an endorsement of the CDC 2006 HIV testing guidelines. The U.S. Preventative Services Task Force, the USPSTF, upgraded from a grade C to a grade A. Clearly, a huge shift in the way we as providers are looking at HIV testing. And the U.S. Preventative Services Task Force recommended ages 15 to 65 for testing, routine testing for patients. Through the Expanded Testing Initiative project, we have developed campaigns to motivate providers and have informed the public about getting tested and to get all of us away from that targeted testing mentality and a new mentality of let's know our status, let's be healthy, let's look at general health, and that includes our sexual health. So what is the goal? Well, I would say here that the goal is to help make routine HIV testing a standard of care in the state of Florida and helping patients know their status. The desired outcome of routine HIV testing will be, if we make routine testing a standard of care, the improvement in survival and quality of life, and the most important thing, preventing new HIV infections. The benefits of individuals knowing their HIV status are that those individuals who are HIV negative can practice safer sex or needle practices and assess if they are a candidate for some new prevention, which is pre-exposure prophylaxis, another in addition to the toolbox of prevention strategies for individuals who are negative but may be engaged in close relationships with HIV positive persons. And for our HIV positive friends and patients, we hope that with their knowledge, they can practice safer sex and needle practices, utilize antiretrovirals per prescription of their very caring healthcare professional, and use treatment as prevention. I have a question for you, another polling question number 4. Based on the CDC and USPSTF recommendations, who should have routine testing, also known as universal HIV testing? A, all patients ages 14 to 65 years of age. B, pregnant women. C, patients diagnosed with STDs, TB, and drug abuse issues. And D, all of the above. If you're with the group, you may have to get a consensus. I know many of you may be watching or participating today in a group setting, so feel free to take a group consensus and still vote in. I'll give you a few minutes since we have 4 options. This is just a sort of stop so that we can be sure we're all on the same page, and hopefully you've gained some new knowledge from what I've had to share thus far in the presentation today. Okay, ooh, very good. For those people that could vote, we have everyone saying all the above, so we have a very bright and capable group on this call today. And yes, if you've gotten 2 points at this point, if I had to summarize, would be this point based on these recommendations, who should have testing, and that would be all of the above. And then the other thing, that HIV transmission and HIV is ageless. Any individual, any age, can have HIV or be at risk for having HIV. Thank you, Ron. So what is Florida up to regarding testing? Well, Florida's been changing. Florida's been making some changes in testing laws. The old Florida testing law was an opt-in testing strategy. Patients had to give written permission in order to have an HIV test. Was this a barrier? I certainly believe so, and I think many people on this call would also agree with me. This was a barrier in such proportion that I'm happy to say that we now have a new Florida testing law, and that is Florida Statute 381.004. And this law was modified to enable healthcare providers to easily implement routine HIV testing into their practices without having to obtain that written consent or perform pre-test HIV counseling. The statute became law in June 2015, and as a result, Florida is considered an opt-out testing state. So what is the Florida opt-out HIV testing language? Well, there's 2 delineated settings. One, the healthcare setting, and then the non-healthcare setting. Those of you on from CBOs today, community-based organizations, may represent non-healthcare settings. But the Florida law requires that before performing an HIV test in a healthcare setting, a patient must be notified that an HIV test is planned and that the test may be declined. Before performing the test in a non-healthcare setting, a provider must obtain informed consent from the person to be tested. A patient in either setting must be informed that a positive test will be reported to the county health department with sufficient information to identify the test subject. And the individual must also be informed of the availability and location of sites that perform anonymous testing. What are the benefits of opt-out testing? Well, of all the 6 I have here, these are all very important, but the number one is that consent is inferred unless the patient declines a test. We've never in the history of testing ever had a test where a patient actually had to sign for it. You don't have to sign for a blood glucose or a cholesterol level or even checking for syphilis or chlamydia. So it is a very refreshing change to have this test, and it supports general sexual health so that we can have informed conversations with our patients without the stigma of having a written consent. The District of Columbia in 2010 was an opt-in district, and they changed to opt-out. And by marketing their opt-out testing program, within 12 months, they had a 26% rise in the number of individuals that came in for testing. So I'm hoping that Florida will start to see that similar benefit because of the opt-out testing that we now have in the state of Florida. Florida statutes also continue HIV testing in pregnancy, and as many of you are very well familiar, we have a first and third trimester opt-out testing for patients who are pregnant. And all pregnant women who present in labor whose HIV status is unknown, they must be tested unless they refuse. But we do test by law all pregnant women in Florida in the first and third trimester. So what do we do with this information as providers? Well, I always like to say that we have imaginary toolboxes as providers. And in our toolbox are many strategies for working with individuals who have HIV or may be at risk for HIV or may not know that they're at risk for being HIV positive. So testing is probably one of the most important things that we need to have in our toolbox, the ability to talk about testing and general sexual health. So if we had an imaginary patient in an imaginary clinic, for example, Dr. Quintana, who I made up, and the Village Care Medical Clinic, which I also made up, we might have an opportunity to test more patients who come in routinely for health care. And in the old days, when I went to school and nursing school, we were focused or told to focus on the strategy of directing our patients, to teach them, to instruct them, and to lead them. But I'm more seasoned now, as many of you are on this call, and what we've learned is the better way to work with individuals is to develop a partnership, to develop a partnership with our patients, to guide them, to draw them out, to encourage them, and to motivate them to think about what is good health and what does that mean to them, and what behaviors may they have to engage in to promote good health and a long, healthy quality of life. So if Dr. Quintana meets Mr. Mendez, let's say her imaginary patient, and he comes in, and let's say he's got an eye infection, and his girlfriend brings him in because he doesn't have a healthcare provider. So he comes in, he has an issue, and it's his eye. He may have a conjunctivitis. Let's take a look. Well, yes, he does. And I'm not going to bore you with the conversation, but in a nutshell, Dr. Quintana has an opportunity to talk to her patient about not only his eye infection, but also about his general health status. So Dr. Quintana takes that opportunity, and she talks to him about the conjunctivitis and what she's going to be able to prescribe, but she also makes a request. She asks, one other request that I would make of you at this time, Mr. Mendez, is that you have a blood test for your yearly blood sugar, cholesterol, and sexual health panel that includes a test for HIV. These are all important tests that are recommended for everyone, all ages, to help prevent health problems early. So Dr. Quintana took the opportunity in this imaginary case to bring up sexual health and other healthily related issues, so that in case she has an option or an opportunity to work with this client in the future on his health concerns and give him good guidance. Again, that word guidance. Now, Mr. Mendez speaks to Dr. Quintana and tells her a little bit about his mother, who has diabetes, obviously, and he even sends money to his mother, and he's worried about her health. She obviously is feeling poorly, and he's concerned about her. Then he says to Dr. Quintana, the cholesterol test sounds good, but he doesn't understand why she wants to have him take an HIV test. This gentleman has never had the HIV test before, and he wants to understand why Dr. Quintana is recommending it now. And I can understand that. He has an eye infection. Why now? And he's also asking a very important question. If he had it, wouldn't he already be feeling poorly? So Dr. Quintana has an opportunity here to give information, and she's going to affirm him. In this scenario, I'm having Dr. Quintana say something very affirmational, which means she's saying something to really build on the strength that this patient is showing. This is a really good question you bring up about HIV, Mr. Mendez. Let me also say that I can see that you care deeply for your mother, and I recognize how hard you work to help her stay healthy every day. And then she goes into giving Mr. Mendez information about sugar, cholesterol, and HIV, and how these diseases can impair one's health. And then finally, she finishes her chunk of information, which is limited because she doesn't want to go too much into a lecture. She asks an open-ended question. What are some of the HIV symptoms that you have heard about, Mr. Mendez, so that they can have a conversation and work together, that she can guide Mr. Mendez and help him learn new information at a pace that he is comfortable with. This was just a scenario of what could have been a missed opportunity for testing. I wanted to give you an example of what my vision might be for those of you that work in clinics that might have opportunities and may be missing them, or your providers may be missing them. I'm going to move on now to HIV testing, billing, and reimbursement issues. What test should I offer? Wow, that's a huge question, and one that can't be easily answered on this call because that is a whole topic in itself and a very good one. I do want to bring your attention, however, to an excellent program that Dr. Jennifer Janelle up the University of Florida did on February 19th, 2015. She did a program that is on YouTube that you can watch, and I have the link for you here. CDC routine testing guidelines and revised testing algorithms. This is a wonderful opportunity for you and your providers to learn more about the different tests that are recommended and the new testing algorithm. The newest test is a combined HIV antibody and P24 antigen test. For those of you that are not familiar with this, what we call the fourth generation test, this test looks for HIV-1, HIV-2 antibodies, and also a protein of the virus, the HIV P24 antigen. And Dr. Janelle, in this YouTube video, does go through this quite brilliantly and very informatively. So I will refer you to her presentation and hope that you will try to view it. Provider recommendations to test matter. I want to bring up on this slide, there is a white coat factor. There always has. For those of you who are providers on the call today, physician recommendations to test is the chief reason why many patients get tested. So if we go back to our little case that we just talked about with Dr. Quintana and her patient, Mr. Mendez, there was an opportunity for the provider to speak to her patient, and she took that opportunity And we're hoping, because the literature shows us that by bringing up the topic, the patient is more likely to get tested after having the conversation. And that white coat factor does indeed make new health strategies and more new health behaviors more available and picked up more readily by our patients. The Centers for Medicare and Medicaid Services, what are third-party reimbursers doing with HIV testing? Well, I'm happy to report that the Expanded Testing Initiative has taken the opportunity to create a guide for you, a provider's guide to reimbursement and sustainability for HIV testing in Florida. This guide has been recently revised in October of 2015. We have these guides, hard copies, and we also have the ability to send it to you electronically. And you can reach us through the usscenter.org. And I really implore you, if you have not seen it or don't have a hard copy or would like the electronic copy sent to you, to please request this, because it has a lot of great information about coding. Here's some examples from some of the pages of the booklet, the ICD-10 diagnosis codes as they relate to HIV testing, also the CPT codes for HIV testing, and some of the office service codes for the CPT codes for office services that you may be able to bill for when you're doing routine testing in your offices. Third-party reimbursements for routine HIV testing. We do have some real program experiences, and I'm happy to say that some of these individuals who are out there being exploring how to go about this are actually on the call today. Two of these agencies were very kind enough to speak with me at great length and share their experiences, their barriers, the facilitators, and the lessons learned thus far as they have been working towards billing for HIV testing in their respective programs. I'm going to first share a little bit about Metro Charities that's located in Tampa, Florida. When queried about their challenges, Christy, I know Christy, you're on the call. Christy outlined about three different, actually four, and looks like my numbering is off. Sometimes when I change these into different I change my slides up, they renumber themselves magically without me. But we do have four challenges here. Number one was getting buy-in from patients. Remember, as we discussed earlier in this presentation, that patients often target themselves as not needing testing and may not feel that they are at risk. So they may not feel that they have an at-risk profile for testing. Number two, provider credentialing process is very lengthy and requires some experience. It's not anybody who can go out here and start that credentialing process. There are especially our providers who come from CBOs or smaller agencies. This may be a very big barrier or challenge. The third challenge is that many insurance carriers are closed and not always open to accepting new providers on their plan. So if you have providers that are ordering routine HIV testing, they may not be accepted by the insurance carriers and may not be able to be accepted for a bit of time because their applications are not being accepted currently by the third-party reimbursers or insurers. And the fourth challenge that Metro brought to my attention was billing for rapid HIV testing is new to most insurance companies, and some carriers may not recognize CPT billing codes, specifically the modifier 92 for CPT code 86703. So I do very much appreciate Metro sharing these important findings and their lessons learned, which you see here on this slide. We have 3 lessons learned. And the first one is the contract that they recommend that you contract with an experienced credentialing company who will complete the application for all the major insurance carriers. Again, this is not easily done, and certainly out of the realm of many of our providers and testers that perform the actual testing. The second lesson learned is perhaps creating a simple workflow plan for HIV testing on the clinical and billing side. Prevention and testing specialists are usually not familiar with billing and may really need some strong support from champions to handle the EMR data entry and the super bill creation. There's a lot to do with this, and it seems to me to be almost a job unto itself. The third lessons learned that Metro wanted to share with us today is that talking with patients is really necessary, and discussing the concept of routine HIV testing in the clinic setting is really necessary, and that providers need to be sensitive to patient concerns regarding stigma and confidentiality. Metro is finding that a lot of patients, even with insurance, don't want their insurance to be billed. They fear very much that EOBs may document that they're having HIV tests, or that this information could follow on to perhaps their parents, if their parents carry their insurance for them, or perhaps their employer. So stigma and confidentiality are still very much barriers and challenges for our patients for testing. Some patients carry their card but won't give the card at the time of the testing. So we know that this must be a very serious concern for our patients. Broward County Health Department is also looking in very deeply and expansively into how they would go about performing routine HIV testing in their program. And their challenges thus far have been regarding credentialing, very similar to Metro, not having an EMR that might be able to take this on, staff lacking knowledge about billing and coding, which again Metro brought to our attention in a previous slide, the need to choose a low-cost and comprehensive billing software. How do you do that? Is it user-friendly? Again, possible challenges and barriers. A lack of time or capacity to perform billing and follow-up if and when payments are denied. There's a long trail of emails and calls that go in to following up when a bill is denied. So having the right people in place that can perform these duties and activities is really important. HIV testing reimbursement rates aren't, big dollars, and so this has to be a consideration as you put together your strategic plan in performing routine tests. And a majority of patients seen at the health department do not have insurance, so this may not be something that many patients will be able to do, that we will not be able to bill for their testing, and so we still need to offer free testing for those individuals who do not have insurance. The lessons learned thus far at Broward County Department of Health, and Nikki Montgomery is on the call today and has been wonderful. Her team has been wonderful in sharing with me some of the issues for them as they develop this strategic plan. Their lessons learned, they have found a free credentialing resource that is available, and that is located on this slide. But there may be other resources out there for many of you who are struggling to find how to approach credentialing. The second thing Nikki brought to my attention was that the billing software, got to have experience with that, need guidance. It is not something simple, and it's hard to create that level of experience without having a good deal of training. And thirdly, they brought to my attention the possibility of considering partnering with another community agency who may already be implementing routine testing or may want to implement routine testing, and combine resources. Obviously, it takes a village in many aspects of healthcare. And is this an opportunity to have that village approach or partnering approach with another agency that wants or is already implementing routine testing? In summary today, HIV and screening, well, we know that HIV is a serious disorder. It is a serious healthcare concern, and we know it can be diagnosed before symptoms develop. And we know that we can promote long, healthy lives among individuals who are HIV positive and prevent individuals from becoming HIV positive through testing and through information sharing and discussions with our patients about sexual health. It is detectable. HIV is detectable by reliable, inexpensive, and non-invasive screening tests. HIV is disproportionately, disproportionately affects people that are likely to be without a regular source of care or that have barriers to care. So we want to be sure that in a minimum, individuals are getting regular health screenings for diabetes, for cardiovascular disease, and for sexual health diseases as well. Infected patients can have years of life to gain if treatment is initiated early before symptoms develop. If they can begin antiretrovirals early, they see very less of the impact that HIV, the virus, causes and has on the body. As we know that HIV, the process of this virus can age the body seriously and bring about comorbidities that an individual may have never seen or may have not seen until many, many years in the future. The costs of screening for HIV are reasonable in relationship to the anticipated benefit. As we know, routine universal HIV testing, we know that the CDC recommends ages 13 to 64. We know that the U.S. Preventative Health Services recommends ages 15 to 65. And we know that Florida statutes support opt-out testing and require that all pregnant women be tested for HIV in the first and third trimesters. So we know a lot. Now we just have to put it into an action plan. We know that current HIV-related policies support routine HIV testing. Community stigma, practice, financial environments, provider knowledge of HIV burden in Florida communities, which is very great. We know that these are critical barriers to universal testing across the state of Florida, and we want to decrease these barriers. We want to know how to do it. We want to get better at this, and we want to see an increase in testing in our state, similar to the way the District of Columbia saw when they did their part in marketing routine HIV testing in the District of Columbia in 2010. Strategies such as delegating HIV testing to nurses may improve implementation of routine HIV testing in primary care settings. A multi-level approach, the village approach, needs to include social marketing, clinic policy changes, and clinic reminders. We think these things can help. You have to let us know if they are, and if you're doing something different or in addition, then please let us know so we can share your good news. The partnerships we as providers develop with our patients can only help to strengthen our resolve to ensure that all individuals who are HIV positive in the state of Florida are aware of their status and linked to accessible, engaging, underline that word engaging, comprehensive, and long-lasting treatment and care. So what is the goal? Please help us all on this call, and those that didn't make this call today, help us all make routine HIV testing a standard of care in the state of Florida. Help your patients know their status. Help them know that we're not picking on them. We just want good health for them, as we want on many aspects of their health care. cardiovascular health, metabolic health, and their sexual health. We have many available resources, and I have to tell you that some of the folks on this call actually helped provide some of these for me. But this is a wonderful slide and very up-to-date on some great resources to help you with your routine HIV testing implementation program and third-party reimbursement. Ron, we can close that one polling question if it's still out there. And at this point, I'd like to open it up to any questions that I perhaps could address. And I'm sorry that it took me a while to get through all these slides, but I hope it's been informative. And I hope that you'll look me up or visit our center at the usbestcenter.org, which is our center website.
Oh, hello, Debbie?
Yes, hello, who's it?
Oh, hi, it's Nikki in Broward County. How are you?
I'm great. I'm just down the block from you, Nikki. Thank you for helping me with the slides. And what question do you have for us today, or comment?
Well, I think, first of all, thank you so much. This is very informative, and it's a great presentation. The one aspect about collaboration is that for government entities who collaborate with CBOs or other entities that are already doing testing, routine testing, there may be an advantageous relationship in the sense that the county health departments could get preferential pricing from the state labs. I have to explore this a little more, but it may be that there could be a symbiotic relationship, or a synergy rather, for public sector entities like health departments in collaborating with the CBOs. I don't think the CBOs on their own can get preferential pricing, but I know that the health departments can get preferential pricing.
Wonderful.
And I think
Nikki,
I think that's in both processing the tests. If I'm not mistaken, it's in both processing the tests and purchasing the tests.
Okay. That's excellent information, and I really got that idea from the collaboration from you, and I thought it was a very exciting prospect, especially for county health departments. And I'm really excited that you're moving on that, and you're looking into facilitators and what Obviously, you've got to broker this with a partner and find out what is advantageous to everybody. So that's a very exciting advantage if that does indeed work.
Yes, it might be something that the Metro folks might want to, when they have a free moment, I know they're very busy, that they might want to contact their local health department and see if there's any advantage in collaborating, if only in the health department supporting them through that.
Hey, Nikki.
Wonderful.
Hey, this is Kirsty from Met. Yeah, that does actually work. We have an MOU with one of our county health departments here to provide HIV testing as well as other STD testing at no cost to the patient through a memorandum of agreement with our county health department, and they use that preferential pricing that they get in order to allow us to do that. So they process all of our STD testing for uninsured or underinsured patients.
Oh, that's great.
Chris, that's wonderful. Excellent.
Christy, is that with purchasing the tests, or is that within processing, like, say, the antibody test?
That is, so our Clearview rapid test that we do, we receive all of those tests through our contract with, we have an ETI contract grant with the state health department. So our Clearview tests come through our funded ETI program, and any fourth-generation HIV tests that we do or STD testing that we do goes through the County Health Department MOU with the state lab, and they provide us with the lab, like the vacutainers and the supplies that are needed for that. But the actual Clearview rapid tests we get through our ETI funding.
Okay, thank you.
Thank you both. I have to thank Christy and Nikki. We've been having conference calls together. ETI project is very interested in working with you, and here it just shows how different organizations are helping each other out, because again, it does take a village. Many of you have asked about sharing my presentation. We have loaded these slides in a format for you on our website. So yes, indeed, please check the slides out. If you have any problems, you can message us through the website. Ron, I know we need to close this thing up. I just want to say thank you to everyone for your engaging dialogue and for your attention and your contributions to the seriousness of HIV in our state. And I look forward to working with you and seeing you in our communities, because I'm out there with you.